Good morning again, ladies and gentlemen. Welcome to the 11th Annual Betty Ann and Wade Heggie Lecture in Integrative Medicine. I'd like to welcome members of the public for joining us, joining our medical colleagues for this lecture this morning. I'll call upon Dr. Dee Maltman to introduce our next speaker.
Good morning. I'm part of the class of 1985, so it's not our year, but I feel the vibe, and I'm excited in 2 years to get back to the parties. I'm pleased to introduce the Heggie Lecture today. And the conference. I'm pleased to introduce the Heggie Lecture today. Betty Ann and Wade Heggie, who are personal friends, were not able to attend today, but we wish to acknowledge their ongoing support of the College of Medicine and thank them for their interest and support, specifically of the Center for Integrative Medicine. It is an honor to introduce Dr. Scott Shannon, who has joined us here today from Fort Collins, Colorado. Scott received his undergraduate degree and MD in Tucson, University of Arizona, his adult psychiatry from Columbia, and his child and adolescent psychiatry from the University of New Mexico. Scott has been involved in holistic medicine since he joined the American Holistic Medicine Association in 1978 as a founding member. He has been instrumental in the creation of a holistic integrative perspective in psychiatry for over 2 decades, and he published the first adult textbook in this field in 2001 and the first child adolescent textbook in 2013. Scott is past president of the AHMA and the past president of the American Board of Integrative and Holistic Medicine. He teaches as an assistant clinical professor at the University of Colorado Children's Hospital in Denver. In 2010, Scott founded the largest and most comprehensive integrative mental health clinic in the United States, the Wholeness Center in Fort Collins. And I would direct anybody interested to go to his website. It's wholeness.com. Amazing video library and all sorts of things, whether you're a practitioner or patient, to spend some time perusing and to see the team he's put together. In 2013, he published Mental Health for the Whole Child, which is a textbook for a book for professionals, and in 2014, Parenting the Whole Child. He spearheaded the Integrative Psychiatric Medical Masterclass for physicians over the last 4 years who want to learn this approach. It's a 5-day intensive that people come to and really understand the approach. On a personal note, Scott and his wife Susie, son Noah, and daughter Sarah enjoy all that Colorado outdoors has to offer, from cycling, snowboarding, climbing, backpacking, and golf. One line I read from Scott's bio in his website really stood out to me. He wrote, "My spiritual life is very important to me, and I have meditated for over 30 years. Helping people makes my heart sing." Please join me in welcoming Dr. Scott Shannon, a clinician, teacher, researcher, innovator, and mentor to many, to deliver this year's Integrative Mental Health Conference talk, the Heggie Lecture. Thank you, Scott.
Thanks, Dee. Well, happy to be here, and I want to thank Dee and Michael and the Heggies and others that brought me here. So I'm really pleased to do this and excited to share with you my thoughts. And one of my goals today is to try to provide an overview of integrative mental health and how it's affected the field over the last 30, 40 years. Another goal I have is to try to be provocative, because I think we need to look at things in a different way, and I really think we need to examine the science and use that as a foundation for a new perspective, and not merely go forward by what we've done before. And I think that has challenges. So one warning that I want to give you is sort of similar to an experience I had with a patient. I was walking back in my office about 20 years ago. I'm walking him back to my office, and he sees an exam room with acupuncture charts and acupuncture models. And I'm an acupuncturist, by the way. And he says, "What's that?" And I said, "Well, that's where I do acupuncture." And he looks at me and sort of shakes his head, and he goes, "I knew you weren't a normal psychiatrist." And being a normal psychiatrist may be a bit of an oxymoron, but that aside. So, well, I think one of the things we need to look at, first of all, is where we're at with conventional psychiatry. Because some would argue that integrative mental health has shifted the field, the practice of conventional psychiatry, very little. So if you go into a community mental health center, at least in the United States, where I'm from, but I suspect here as well, I think what you're going to see is the delivery of a lot of psychiatric medications that are repeatedly changes to people dealing with chronic mental health problems. You're going to see the delivery of psychotherapy, which will be sort of repetitive and intermittent. And you're going to see people struggling with chronic mental illness that often endures for decades. And that's sort of the pattern of what we see in the United States. So let's drill down and look at it. Now, there was a major article published in The Lancet in February. And this article was the biggest meta-analysis of antidepressants that have been done. It was looking at over 500 different trials, over 100,000 different patients, 21 different antidepressants. And not only did they review all the published data, but through the Freedom of Information Act and other things, they accessed the 52% of trials that had not been published. So this was critical information. And the article that was published in The Lancet celebrated this by saying, antidepressants work. Now, they didn't drill down and say, but they really work so poorly, they don't really have any clinically meaningful benefit. Now, this is an echo of what Kirsch found and what Turner found in their similar meta-analysis done in 2008 and 2010. Now, when you drill down and look at the data and try to separate out the difference between a relative shift in the cone's effect size and go to an absolute difference in the effect size, what you see is something remarkably different. So the cones is a measure of efficacy or effectiveness. And when you look at it, what you find is that you really need something on the order of 0.4 or 0.5 to have a clinically meaningful benefit. And in the prior trials, what they found is that although antidepressants did show to separate from placebo, the 2 or 3 points on the Hamilton Depression Inventory that they separated was not clinically meaningful. And this larger trial published in The Lancet that celebrated that it actually works, when you look at the absolute effect size, what you see is that only one of the 21 antidepressants showed an absolute effect size of over 0.5. And that is considered the threshold where you can see a clinically meaningful benefit. There were 1 or 2 that had 0.4 or better, but the vast majority of them were less than 0.3 or 0.3 to 0.3.4. And so basically you could say that 17 to 18 of the 21 antidepressants in common use around the world show negligible clinically meaningful benefit. So let's step back from that. Let's look at some other areas. Let's look at reliability. The DSM-5, which was published a year ago to great hoopla and great profit to the American Psychiatric Association, I might say, what they found was that in the field trials for depression and the new criteria that they've used for depression actually show less reliability than the field trials for DSM-3 published in 1980. So that means that as a field, the reliability of our most important diagnostic groups, and this is true of anxiety as well, our most important diagnostic groups have gone backwards. And the reliability in these trials is on the order of 0.3 and 0.32, which is really fairly horrific as you consider. You know, in medicine, we consider reliability of a diagnostic group, you know, if it's 0.6, 0.7, that's really decent. And in psychiatry, we roughly have throwing darts at a dartboard. And that is really, I think, profoundly concerning. And it's not that people in the field are not trying, it's just that the complexity of what we're trying to manage is so inordinately complex that it exceeds our ability to categorize it or predict it very well. If we look at some other areas, for example, the use of antidepressant medicine, there's increasing concern that the chronic use of antidepressant medicine actually makes people have a more difficult and protracted long-term course. And the New York Times had a front page above the fold headline 2 months ago talking about the great difficulty that people are having getting off their antidepressants. And what we have in the United States is we have 15 million people that have been on antidepressants 5 years or more. And they did surveys of them both in the United States and New Zealand, and what they found that their most common complaint was they can't get off them. And if you try to come off them, your body becomes so habituated and dependent to the neurotransmitter pattern that it sets up, it creates horrific side effects. Electrical shocks in the brain, shaking. I don't know if you guys, have you had trouble getting people off antidepressants in your practice? I mean, it's difficult. And let's not even get into benzodiazepines. That is a whole nother category. So, I mean, just taken as a whole, we can step back and say that psychiatry is struggling. The chemical imbalance theory of depression that came on with great hoopla in the 80s and early 90s is really dead now. No serious neuroscientist embraces the serotonergic theory of depression, period. And we really have, almost never did, have any solid evidence that that was a scientific theory, more than just sort of a fancy urban legend that helped to market SSRIs. So where do we go from here? And we could look at the same sort of concerning overview if we were to look at the treatment of PTSD, and that we really have no really good treatment for PTSD. The United States spends over $10 billion a year treating PTSD in veterans, and what we now find is that every single incident that we get into in our history, every one has a higher rate of PTSD from the people involved in it. And some would say that the rates of PTSD for people coming back from Iraq and Afghanistan are in the order of 10 and 20%. And certainly we know that 10% of the veterans in the VA system are dealing with PTSD. Our current treatments, which are SSRIs, show a negligible, modest to mild benefit in 3 to 6 weeks. But as you start looking at 6 months and 12 months, you see really negligible and failing benefit. Our psychotherapy is actually now considered our best treatment model, and that alone struggles with effectiveness and durability as well. If we look at addictions, you could make the argument that modern psychiatry has failed to improve the outcome of addiction treatment over the last 50 years. Now, some people would argue that with our use of clonazepam, alprazolam, and other chronic benzodiazepines, not to mention the dependency that can be created with other psychiatric medications, that we may actually have had a marginally negative benefit. But certainly addiction treatment remains notoriously difficult and marked by chronic recidivism and a medical model that really has no traction. So let's just set that aside, this look at sort of modern psychiatry. And I think you could say that modern psychiatry is struggling. Our paradigm of using suppressive drugs to minimize symptoms and attack illness has been of mixed benefit. And I think people are now looking for a new model, a new approach to treating mental health disorders. And I would argue that integrative mental health, and the talk today will really ensue, is to give you a frame of mind of why integrative mental health offers some hope and insight to psychiatry to go a different direction. So, faculty disclosure, I'm a PI researcher with MAPS, Multidisciplinary Association for Psychedelic Studies, which is one of the few nonprofits that has gotten to phase 3 trials for benefit and all beneficial medication. And I'll talk about that in a little bit. And I've written 4 textbooks. We've received support from the Heggies and Highlights in International Medicine Conference, and we've also got support from the College of Medicine in the form of an educational grant. And I will not promote my 4 books, and I shouldn't just go and elaborate on the titles and say that I will not promote them. And I'm only going to talk about published data from the phase 2 trials and the clinical design of phase 3. So in the agenda, what I really want to talk about is why we need integrated mental health. And I think this prelude that I gave you before sort of sets the stage that we don't have a wildly successful approach to mental health as it currently stands. It's inordinately complex, it's very difficult, and it's still marked by relapse and struggles for people that often endure for a lifetime. And what I'm going to do in terms of elaborating a new model is first talk about the foundations of integrative mental health, the roots of it. I'm going to talk about some of the major discoveries over the last 40, 50 years that I think really have set the stage for this. We're going to talk about what the future might look like as integrative mental health continues to have more influence on the development of psychiatry. And then we'll have time for discussion and hopefully not a lot of rocks and tomatoes thrown at me. Okay. So never, ever think outside the box. Now, I've been accused of my colleagues of soiling the professional carpet, but I tell them it's still thinking even if it's thinking outside the box. So what is integrative mental health? Well, here's just one stab at it. It combines the safest and most effective techniques to support the health of body, mind, spirit. And that is really interconnected, so it's hyphenated as opposed to different words. In an ecologically sound approach, and ecologically I mean not just environmental toxins, I mean using ecology as a science of interconnected systems. That we're interconnected in community, we're interconnected in terms of our physical environment, social, we're interconnected in our physical health, our mental health, and that these become just one large, interdependent, intercommunicating system that emphasizes prevention, the removal of barriers, and the correction of underlying imbalances. And I put down there as a parenthetical is that physical, mental, emotional, social, or spiritual issues may predominate. And this is really bowing to that ecological model that people can come in with psychiatric disturbances, and it may be an existential problem, and it may be at its root a toxicological problem, it may be at its root a social problem, a relational problem. And these all sort of interdigitate and interconnect. So I mentioned these, and I sort of went through this. This is why we need it. And we could probably make this list go over, but I thought we might as well deal with some of the more common and challenging ones first. So if we're trying to sort out what is the difference between integrative mental health and conventional mental health, it really comes down to a fairly simple dichotomy. And this would be true of integrative medicine versus conventional medicine. What is the big difference? What's all the hoopla? Why is this different? Well, the hoopla is about the underlying premise, the foundation of your care and approach to each patient. So one approach is that we deal with people that present with illnesses, and that our job as physicians, as providers, as caretakers, is to attack the illness that they have and conquer it. It's a warlike approach. You'll notice that most of our medications have anti in them, whether it's anti-nausea agents, antidepressants, etc. And we wage war on this illness. For example, the war on cancer. We attack, and we are going to show no mercy. Now, when you wage war on something, you often have collateral damage. And I think, unfortunately, in this warlike model, we've become a little too tolerant of the damage that we can cause with our powerful tools. And I would contrast that with the approach in integrative medicine, which really has a foundation of health and says that the body has the ability to heal itself. I mean, if that weren't true, most of us would be sick in this room right now. The body has this ability to stay healthy, and health is the default setting in our body, and illness becomes rather the abnormality, and that we can address and support as physicians and care providers. So in integrative medicine, we have this foundation of health, and the body has this power to heal, and we don't want to impair that in any way. So because of that, we follow that Hippocratic dictum, first of all, do no harm, primum non nocere. We do not want to impair the body's ability to heal. And because of that, we were going to use the safest treatment. You know, I think both branches of medicine would say, if there were an ideal treatment that is perfectly safe and completely effective, there is no difference, there's no argument, we're all in the same boat. We all want evidence base. We all want documentation that these things are true. But I think that foundational difference starts to make, when you have a treatment, let's say you have a treatment for treating congestive heart failure that has 5 out of 5 for efficacy and 3 out of 5 for safety, you may see integrative medicine practitioners go for a treatment that is 5 out of 5 on safety and 3 out of 5 on efficacy because of this philosophical divide. You can have the same patient, the same selection of treatments, but that philosophical filter makes you arrive at a treatment plan in a different way. So this is really this sort of fundamental divide between conventional and integrative. There's an article I wrote with Andy Weil and Bonnie Kaplan from Calgary a few years ago where we talk about this, and that really when you're in this sort of difficult situation where you have a highly effective but perhaps dangerous treatment or a perhaps moderately effective but incredibly safe treatment, who makes that decision? You know, the medical model predominantly has been a paternalistic model where we decide and deliver our recommendations down from on high. But I think the integrative model recognizes that this needs to be collaborative, that this needs to be a process of discussion, and the patient's sort of dichotomy in that way should drive these decisions. And that if we have practitioners who only know one model or the other of this divide, are patients really getting full informed consent? Do they really know what their choices are? So just arguing that we really need to be able to discuss both sides of this divide and understand it. And I think perhaps that's why I'm here today, is that we can sort of broaden our thinking and understanding of these topics. So Carl Jung, in the upper left-hand corner, whose writings actually over time have become more popular, whereas Sigmund Freud has fallen off in the last 100 years in terms of popularity, Carl Jung's influence and popularity continues to grow. And what was one of the reasons for that is that he really had an understanding of the psyche as something that had an inner intelligence, the self with a large S, he called it, that had the ability to guide us, and that dreams offered us a path to healing and insight. But he also had this deep belief that the psyche was a guiding force that could help heal us and cure us, and had this inner power to heal. And he's perhaps one of the first sort of early foundations of integrative mental health. There have been others. William James wrote about spirituality, and I think had a very deep understanding of that. Wilhelm Reich understood the connection between body and even body habitus and our psychological state. The human potential movement with Abraham Maslow, Fritz Perls, and others really saw that people could expand to greater than they were, and this movement towards our untapped potential that started in the 50s and 60s with these men sort of continues to this day. And then we have the very interesting work out of this area in the world with Humphrey Osmond and Abram Hoffer and actually Stan Grof in Czechoslovakia and then at University of Maryland. And this is important not so much for the fact that LSD is a transformative agent or is magic or is completely safe, but the fact that they were using these agents to trigger change in people that could create lasting benefit. And that has continued to have dramatic influence on this field now 60 plus years later. And I think, you know, in great tribute to the thinking and the developments that came out of this part of the world at that time. And Elmer Green, in his work at the Menninger Clinic in the 1960s, showing that yogis who came to this country had the ability to alter their physiological parameters in ways that we did not understand or certainly could not document before that time. He showed that yogis coming in from India could decrease and increase their heart rate at will, often throw their heart into ventricular fibrillation at will. They could alter their blood pressure. They could do things, decrease their oxygen demand in ways that were just extraordinary. But he leveraged those findings to go on and show that everybody could actually change their physiological parameters if they got feedback for it. And that through operant conditioning, people could learn how to control their blood pressure or their muscle tension or their galvanic skin resistance. And these are things that are just sort of outside our everyday awareness, but when we have some trigger for it, then it becomes possible to manage it. Having a little bit of trouble. So let's take a look at some important advances in the field over the last 50 years. This is not working well. Okay. So here are a few areas that I want to get into, and I say this is selected key arenas because, you know, we could pick other areas, but these are ones that I think have pivotal importance, pivotal value, and continue to have impact on the field. So Herb Benson's work at Harvard in the early 1970s, in a pivotal article here published in Lancet, showing that the relaxation response, which is really just his term for meditation, could alter key physiological variables. And, you know, ranging from decreasing blood pressure, decreasing heart rate, and most importantly, showing that the energy demands of the brain were dramatically less. And actually, those findings have continued as we approach our understanding of the default mode network and the intrinsic brain activity that accounts for as much as 70–80% of the ongoing energy demands of the brain, that can be remarkably decreased with meditation. And that when you're meditating, the energy demands of your brain are less than while you're sleeping. And the benefits that have come from meditation, and Jon Kabat-Zinn has shown this with his MBSR program, that these, not only do they help people manage chronic pain, but they also help people with depression, anxiety. It appears that meditation appears to help most every significant thing that we deal with, at least that has this sort of mental emotional interface. So the work of Herb Benson and Jon Kabat-Zinn, pivotal in the development of understanding the value of meditation. And meditation may be just one self-training technique, and there may be a much broader arena, but let's just keep it focused on meditation for the time being. So Elmer Green worked at the Menninger Clinic in the 60s and 70s, and he really was maybe not the first to understand biofeedback, but certainly popularized it and helped us to understand that people can train themselves. Our brain, we're now understanding that the brain is resilient, and it is something that can be trained and has the ability to train itself. Joel Lubar and others did first work with neurofeedback, which uses the same operant conditioning, but instead of using a physiological parameter like heart rate or blood pressure, he uses EEG waves. And his work here in 1975 showed it could improve seizures. And then later, he showed that it could improve ADHD. ADHD has a clear encephalographic pattern on EEG where you see slowing of the frontal lobes. And if you increase frontal lobe frequency through training, people's ADHD improves. So these are developments that have greatly enhanced our ability about potential and the ability for people to improve themselves. Exercise. We know that exercise is an effective antidepressant. It may be one of our best stress moderators that exists. If we exercise regularly and routinely, we seem to be healthier, we seem to live longer. And you know, what's interesting is the definition of exercise may actually be, you know, it used to be, well, you'd have to run 5Ks and marathons and 10Ks. And they're actually finding that probably vigorous walking gives you the same physiological, psychospiritual benefit of hard exercise. And it may be that hard, extreme exercise, like running marathons, may actually be counterproductive. And the people that seem to live the longest around the world, and there are these pockets, the blue zones they're called, one of the predominant things about these cultures is they're physically active. They move. They're not running marathons. They're just gardening and walking. They walk to town 3 miles and back and forth. They're putting in their 10,000 steps every day. They're healthier and they're happier because of it, and they live longer. Natural supplements. I mean, there's a range of natural supplements, often that work in concert with the body's own physiology to support health. So SAMe has been shown to be as potent as any prescription antidepressant, without sexual side effects, no black box warning in the United States that it increases suicidal ideation, and we know the physiology that it works through the 1-carbon cycle and makes exquisite physiologic sense. Andrew Stoll published his first work on omega-3 essential fatty acids, showing that these have benefit in mood disorders. And we now know that, for example, when you supplement with omega-3 essential fatty acids, your risk of sudden cardiac death falls in half within 2 weeks. Boom. I mean, why shouldn't we all be taking this? Well, we should be. And we know that it has benefit for depression. We know, for example, it has benefit in treating ADHD. The effect size of omega-3 essential fatty acids in treating ADHD are as good as the effect size of antidepressants in treating depression. But how many people routinely use omega-3 essential fatty acids in their practice for ADHD conversed with SSRIs? Then we have the work of Charlie Popper, Bonnie Kaplan, and others around broad-spectrum micronutrients. There's a very interesting story. This came out of your neighboring province, Alberta, southern Alberta. A gentleman by the name of David Hardy and Tony Steffen. Well, Tony Steffen was a dad that had 2 severe bipolar children. His wife had recently committed suicide because of severe bipolar illness. He had tried every conventional treatment at the time, and this was in the mid-90s. And he turned to his neighbor, David Hardy, who was an animal nutritionist, and said, I don't know what to do. My kids are wild, they're suicidal, they're hospitalized frequently, they run around with knives threatening each other and us, and I can't manage this. And David looked at him and said, your kids don't need a medication adjustment, they need a feed adjustment. And he said, when I manage large plots of animals, 10,000 pigs or 1,000 pigs on a farm, we can't medicate them when they get aggressive. We just realize they need a different combination of minerals and trace elements. We adjust that and the behavior improves. And so he created a formula for these kids. The first 2 iterations didn't do much. The third one, they got benefit, and they've continued to improve it. EM Power, the product those 2 developed and that Dr. Popper wrote about, now has been used by over 200,000 people around the world in a database, and there's 40 published peer-reviewed articles on it in the treatment of depression, ADHD, but particularly bipolar disorder. And it is still my go-to treatment for treating bipolar disorder. Charlie Popper was the original editor. He's a Harvard physician, Harvard child psychiatrist, the original editor of the Journal of Pediatric or Child and Adolescent Psychopharmacology. And he now believes that EM Power and its next generation is the most effective treatment for bipolar disorder that he's come across. And that, I think, has had rippled effects that we can treat severe psychiatric illness with nothing more complicated than micronutrients. And then finally, we have the work of Klaus Linde and others in their review of St. John's wort for the Cochrane meta-analysis. And the Cochrane meta-analysis may be one of the highest bars for evidence-based medicine that we have. And what they found, and in comparison, and this is in major depression, because people will say, oh, St. John's wort, that's okay if you have mild depression, but I wouldn't use it if you're really sick. So this was a meta-analysis of, I think, 29 different studies in major depression, comparing it to antidepressants. and found that it's similarly effective as antidepressants in treating major depressive disorder with fewer side effects. And actually, one public health study out of Australia found that if we actually used St. John's wort exclusively for treating major depression compared to SSRIs, we would save money because such a high percentage, like 20% of people on SSRIs, come back in for another medical visit because of side effects from it that we don't see with St. John's wort. In the last 10 years, we've had Felice Jacka out of Australia publishing all these studies showing us that people that have traditional diets, and a traditional diet means that it's got fruits, got vegetables, got nuts, it has some meat, but it's not overwhelmingly processed foods, not overwhelmingly sugar and flour, not overwhelmingly sweets. Those people are psychologically healthier. And one of her most interesting studies, the first one there, she looked at a group of adolescents in Australia, a big group, I think 3,000 kids, followed them prospectively over time, and found that as these kids' diets were improving, their mental health improved. And as their diets were deteriorating, their mental health deteriorated. And they did not see reverse causality. And basically, I've come to believe, after being in this field for 30 plus years, is that if we can shift someone's diet, we stand a much better chance of getting them to a stable, productive place for their mental health. It's not a cure-all, but it's certainly a significant foundation that works for very many. And we have the whole arena with positive psychology. I love the title of this one. This is from Barbara Fredrickson's. Open hearts build lives. Positive emotions induced through loving kindness meditation build consequential personal resources. The whole emphasis in positive psychology is that we can enhance people's well-being through positive tools, such as this loving kindness meditation. And there's this whole development of positive psychology that is taking root and is giving us a different view of psychology, that we don't just have to focus on people's illness, but we can actually take people that are struggling and give them tools to build themselves up, as opposed to always having to be symptom-focused, distress-focused. And I think that's one of the great benefits of positive psychology. So, I want to talk a little bit about what I call the twin pillars of integrative mental health. So where do we go from here in terms of modern psychiatry, in mental health in general, not just integrative mental health? Well, I think there's been two developments in the last 20 to 30 years that tell us more about how the brain works, the sort of honest reality of biochemistry, biology, and genetics, and brain function, that indicates where we need to go to create a positive, productive model of mental health. And I think those two things are neuroplasticity and epigenetics. So let's start with epigenetics. I think in September of 2014, there were 30-some papers published simultaneously around the world from 500 different researchers. This was the ENCODE data, Encyclopedia of DNA Elements. And what they did is they looked at a small snippet of human DNA. I think it was 4%. And they wanted to understand what was going on, particularly with this concept called junk DNA. I don't know if many of you guys probably are from the same era that I was in terms of medical training, but I remember this very clearly, is there was 2 or 3% of DNA that actually did something, and the rest we called junk DNA because it probably really didn't do anything. Never mind that it was meticulously preserved over millions and millions of years of evolution. It probably didn't do anything. And that we are most interested in this junk DNA. And that once we got the human genome elaborated, we would understand all human illness, and our treatment of them would be profoundly different. Well, the Human Genome Project has come and gone, and how much has it altered the practice of psychiatry? Some people would say not at all. Some people would say 1%. We now have some genetic tests that we can do, like Genomind or GeneSight, in the US, that give you some predictive value for how you metabolize different pharmaceutical agents. And then we have the MTHFR SNP that looks at folate metabolism. But aside from those little things, that we don't really have any use for the human genome data. But this ENCODE project really began to look at, well, what does the rest of this 97% of our DNA actually do? And I think what they found was really dramatic and instructive, and it makes us realize that epigenetics is actually much more powerful in understanding mental health than genetics. This is Randy Jirtle's work out of Duke, I think in 2004. And what he did is he took agouti mice that are bred to be obese and diabetic, and he altered their feed. He randomized them, and while they were pregnant, he altered their feed and gave one group standard Purina mice or rat chow, and he gave the other group that plus methyl donors. Now, methyl donors are things like B12, SAMe, choline, that contribute methyl groups that help support metabolic processes in the body. And we know that many of these things are useful in treating depression and psychiatric problems. Well, what he found is that the offspring that got no dietary supplementation, most of the mice looked like their parents, obese, diabetic, and unhealthy. But the group that got dietary supplementation while pregnant was predominantly healthy. The agouti gene was silenced by methylation. And this becomes, I think, evidence for what epigenetics actually is. Epigenetics is the ability of our environment to influence the transcription of our genes. We inherited a set of genes from our parents. We can't change that. It's locked in stone. But we can alter what we eat. We can alter our emotional environment. We can alter our spiritual health. We can alter our physical exercise and fitness. And diet may be the single most profound, diet and exercise are probably the two single most profound influencers on epigenetic expression. And if we look at the role this plays, these things all from outside of us alter genetic expression within inside each of our cells. And this becomes our translation of our environmental process into our health. So most people argue, and this is why the Human Genome Project really failed to give us much bang for the buck, because as you can see here, SNPs explain some percentage of the difference in what happens to us, but not even a majority. It's a small minority. And so what we see here is that the environmental influences are much more profound than our genetic heritage. Our environmental influences are much more profound than our genetic heritage. And when you look at the genetic data that comes from these genome-wide association studies, what they tell us also is there's a dimensional model for depression, ADHD, and likely other things that they've looked at. And what that means is there's not a group of sick people here and then well people over here, but with ADHD, it's probably a bell-shaped curve, like how fast you are, how tall you are, what's your IQ, any other normal human trait. And because of that, we have to understand that if we're trying to treat people with ADHD, we have to just pick a point on that bell-shaped curve and say, you're sick over here, you're healthy over here. Well, that's kind of crazy, a little bit crazy. And as a result of that, there really is no boundary line. People come in and, they'll say, well, I really want to get into an Ivy League school and my parents are pressuring me and maybe I should get on stimulant medication. Well, maybe they're slightly more impulsive and inattentive than average, but how do you say no to that? I mean, is there a dividing line where it's just, no, you can't have stimulants? And we get this whole area of cosmetic psychopharmacology as a result. It's very difficult to manage. And I can tell you that as a child and adolescent psychiatrist, it becomes a real challenge. This is sort of boilerplate from the CDC. Genetic variations do not cause disease, but rather influence a person's susceptibility to environmental factors. virtually all human diseases result from the interaction of genetic susceptibility and modifiable environmental factors. Let's highlight modifiable. We can alter diet, we can alter exercise, we can alter meditation, we can alter the biochemistry created by our physiology. This alters gene expression. And it's a majority influence. We also know that childhood experiences, this is the ACE work of Vince Folletti out of San Diego and Kaiser Permanente. And what they found is that ACEs correlate in graded fashion with every negative outcome in affective, somatic, memory, substance abuse, aggressive, and sexual disorders. But other than that, it has no relevance to psychiatry. That was a joke. This may be our single most profound variable that we can manage. And you know, right now what we find is that we're managing people at the tail end of this. Wouldn't we be doing better to prevent these problems? Isn't that our sort of biggest imperative that we have in mental health, is what can we do for children and young families to try to reduce trauma in childhood, because it's going to correlate to the bottom line when they're 50 and 60 years old. It correlates the bottom line in terms of their demand on the healthcare system. In our area, we have a service that goes around to emergency rooms to deal with the frequent flyers in our emergency rooms, high utilizers of the mental health care system. By and large, almost always, these are people who have ACE scores of 7, 8, 9, 10. And what can we do to help manage this more proactively? But this is another reflection, and we'll see why. This is a reflection of these epigenetic influences. This is work out of McGill University, and what they found looking at people that had completed suicide was that people who have an abuse history are much more likely to have epigenetic changes in their brain that probably through cortisol mechanisms lead them to experience chronic mental illness and be much more likely predisposed to commit suicide. So there is mortality to this problem. The other thing that we can understand from epigenetics is this can create decades-long influence. We know from the Swedish farmers' data that epigenetics can actually create effects that last for generations. Generations. So neuroplasticity, I'll run through this a little bit. Neuroplasticity includes new cells, but also dendritic growth and change. Here's an interesting study that looks at what can possibly be done. These are adults with mild cognitive impairment. They put them on an exercise program, give them supplements, talk to them about diet, and give them 2 hours a week of neurofeedback. And they find that even people with mild cognitive impairment who predictably have gone on to develop Alzheimer's can turn their brain around. This is proof that even in late life with really problematic symptoms, we can turn our brain around. It is plastic. Neurofeedback, it just makes sense from an electrical point of view that we can monitor this stuff in almost real time, and that it actually has good resolution in terms of being able to understand where in the brain these problems are occurring. We have good evidence that it can treat ADHD, and this is an effect that is not related to simply symptom suppression. Here's some electrical neuroimaging using Loretta technology showing places in the brain where we can create changes within 10 treatments in abnormal brain regions of activity. So the red highlights that there's more 2 standard deviations off norms. And after 10 treatments with neurofeedback, that can be corrected. This translates into behavioral, cognitive, and affective shifts. So some new ways of thinking. There's PANS and PANDAS. And this is something that's been around since Sydenham's Korea was described over 100 years ago. But we're now recognizing that it can be predominantly a neuropsychiatric problem. And it's probably because of beta hemolytic strep and other infections that alter the basal ganglia. I'm not going to get into details on this, but just really show, number one, it can have this enormous range of behavioral issues in kids. But most importantly, what we see is that it can affect adults as well. This is a an author who wrote this book after she was psychotic for a month. She was evaluated at Bellevue, felt to be psychotic, and they couldn't understand what was going on. And she was about to be shipped off to a chronic state hospital when a neurologist evaluated her, had a sense that maybe it was an NMDA receptor encephalitis because she drew a clock and it was so distorted. He said, that's neurological, that's not psychiatric. And she was put on steroids and given some other treatments, totally recovered. And how many people exist with that type of problem? Probably a lot. This is a new medication that's been out in the States. We think it's got great potential. I think it's a new path forward for psychiatry. And next year, they're going to come out with a continuous delivery formulation of it. So let's not say psychopharmacology doesn't help. We can modulate our mitochondria. They produce energy for the body, critical in brain function, critical in psychiatric illness. And what's interesting is we have 7 known modulators of mitochondrial function, and most of those I use in my office for integrative mental health, even before I knew they were mitochondrial modulators. So this is another path forward for psychiatry. Inflammation is a critical element. We know that people with high C-reactive protein, not only does it create heart risk, but it creates brain risk. And people with high CRPs show declining frontal lobe function, but they also show an increased predisposition to depression. So this is a survival curve showing that the people with the highest CRP levels actually become more and more depressed over time. If you have an inflamed brain, that is not a healthy brain. And how many psychiatrists monitor and manage inflammation in the body? Not many. Psychedelics. This is building on the work of Osmond, Humphrey, and Groff, and we're now having this whole resurgence in research on psychedelics. A lot of neuroimaging research, a lot of research around depression. I'm involved with the MDMA research. This is an avenue that is sort of a new path forward where we're looking at elements given very selectively, often 1 or 2 times, that can have a profound, lasting change on people. The risks are not what we think they used to be. In the MDMA studies in phase 1 and phase 2, over 1,000 treatment episodes without a single adverse event. In the psilocybin work, phase 1 and phase 2 studies, almost 1,000 treatment episodes without a single serious adverse event. So they're not without their risks and problems, but in a controlled medical psychiatric setting, they have good potential. MDMA, just a little talk about its neurotransmitters. It works on a lot of different systems, but also not only does it include serotonin, but also prolactin and oxytocin, which may help us understand its value in PTSD. 20 psychiatrists were asked about their experience with MDMA. I was actually one of the psychiatrists that used MDMA in the 1980s before it was scheduled by the DEA in 1985. And my experience was very similar to this. Increased awareness of emotions, decreased fear, decreased defensiveness, enhanced ability to be open. There is probably, if you were to design a psychotherapeutic stimulant or adjuvant, it would probably look like MDMA. It enhances and speeds psychotherapy. And the treatment with MDMA in PTSD, the trial that we are doing down in Fort Collins, it's very different than what you might imagine. People have headphones on, eye shades, they take the MDMA, and typically they go inside. It's non-directive supporting, we're there, it's a co-ed therapy team, and we're really depending on the inner healing intelligence of the body to lead us forward. They're reclining with headphones, eye shades, music, and they come out and talk to us, process, but then we direct them back in. And this really gives us the ability to, I would say the body knows what it needs to do. The MDMA seems to take the amygdala and the limbic system out of their trauma so they can actually think about it and process it in ways that they couldn't do before or without that support. The studies show that A CAP score of 50 shows severe PTSD. 35 is the criteria for PTSD, but 50 is very severe PTSD. We're treating people that have been often treatment resistant over decades, failed many different medications and psychotherapy trials, and this is what it looks like. And the summary data from all the summary of all the published data from phase 2 with MDMA shows that after 2 months, 62% of people no longer meet criteria for PTSD. This is 2 months after their last exposure to medication. They have 2 or 3 drug treatment days spaced a month apart with psychotherapy. And after 2 months, 62% no longer met criteria. But after 1 year, 68% no longer met criteria. Unlike the SSRIs, which fade over time, MDMA improves over time, and I think it's because we're showing a training effect rather than a suppressive effect. I'm going to skip over ketamine. I'm getting bored, Mom. Let's cut to the chase. So, this is a very interesting study done at NIMH a little over a decade ago. And what they did is they took 9 psychiatrists and had them work with people with major depression with either placebos or imipramine, which is a very good tricyclic antidepressant. And what they found is that the psychiatrist was actually much more important than the medication. So if you got a bad psychiatrist and imipramine, you did worse than a good psychiatrist with placebo. So what I want to do in just summarizing, sort of pulling this all together is, I think we need a new model in psychiatry. I think we really need to understand that we need to move forward with a model that embraces epigenetics and a model that embraces neuroplasticity. I think we need to move beyond this sort of failed model of suppression of symptoms, which I think leads to dependency and all too often chronic problems. And we need to come to a new model that is based on relationship, is based on our connection to our environment, which includes our food, our community, the people that we relate to. And I think we need to move to a model where we respect the elements in the psyche and we can begin to bring them forth and understand them and not be afraid of them and move away from it. But I think most of all, we need to move to a model that's humanistic, supportive, emphasizes prevention, and allows us to be honest with what works and with what doesn't work. So I think with that, I'm going to close and invite discussion and comments.
Thank you, Dr. Shannon. I'm going to depend on the audience to help me out, as I'm a former general surgeon. So if we couldn't surgically remove the problem, it wasn't worth looking at. So do we have some questions for Dr. Shannon?
Well,
Yes,
thank you,
Taylor.
Dr. Shannon. That was perhaps one of the best lectures I've ever heard. Thank you very much. Question I have with your MDMA study, you went through fast. Was that a single treatment or was that repeated several times?
The protocol used in phase 2, which is fairly similar to phase 3, basically involves about 50 hours of contact time with a practitioner like myself, who's in a team with another practitioner. It involves 3 sessions, 90 minutes each, of prep, and then a 8-hour session under the influence of MDMA with us sitting by with them. They spend the night with a sitter in our facility. We come in the next morning. If they're good, we send them home. They have 3 more integration sessions over the next month, another 8-hour session with MDMA, 3 integration sessions over the next month, another session with MDMA, 3 integration sessions, and then a 2-month follow-up. It's probably overkill, but I think the intention was, let's show that it works, and then we can dial it back from there.
Yes, sir.
Yeah, thanks very much. Excellent lecture. And what I wanted to ask you about is a question of motivation. So like you've kind of laid out a pathway towards good health, good mental health. But how do you help somebody to take that path, change their diet, start to exercise properly, get into the right sort of mental environment and so on, when they don't have the motivation to do that? Have you given thought to that?
Yes, the question's about motivation. So a couple things. One thing is that I understand that people that are so depressed often have a deficiency of motivation, if you will. But often when they come to see me, they've tried everything. They've tried 5, 10, 15 different medication trials. They've really been struggling and unsuccessful. And what I do is I try to reflect that back to them, saying, well, should I be the psychiatrist that prescribes number 16 to you? Is that likely to be helpful? And I just try to be very honest with them about what I see. And what I see is that I think that I could likely get things a little bit better for a little while with another medication, but it would likely crash in a month or 2 or 3, and you'd be back sort of where you are now. I said, or we can really look to do some more fundamental changes that I think could alter your life trajectory. And I'm going to sort of leave that up to you. Which would you prefer? And I try to sort of speak to them on a deep level about that, with honesty and compassion, but also with directness. And most people will say, yeah, I'm tired of this. I'm tired of this merry-go-round. And I sort of lay out what it might look like. But I also realize that I'm going to need to do some things that are going to help them fairly quickly, because that sort of inspirational moment from my pastoral zeal is only going to last so long. And so what I will do is I may start them on some SAMe or a B-complex with methylfolate. I'm going to try to do some things to relieve some burden. We're going to work at changing their diet right off. And I may try to get them involved in some other things. For example, just moving. You know, get out and your spouse is here, they're inspired, get out and walk with them 10 minutes a day. Start with 10 minutes, walk around the block. You can do that. You know, it doesn't have to be a marathon. It's just getting them moving. So I think you need to make it incremental. You need to provide supports. I think we work with 3 naturopaths in our clinic, and probably half the people I see get routed immediately in for work on their diet and lifestyle. And we try to correct sleep issues. We try to remove barriers, that concept of removing barriers. I'm not sleeping well, and you're drinking 5 Diet Pepsis throughout the day. That's probably related, maybe why you're anxious too. And so it's making sort of simple, fundamental changes, inspiring them, but also giving them tools and helping them along and realizing they're going to need some support and encouragement. But it's no doubt a challenge. And I do think that some people aren't up to that challenge, and that really limits what we can do. But I think if you're deeply honest with people about their situation, people respond, and they hear it on that deep level. And I think if you just come in and say, well, you just need this new antidepressant that we found, I think it's going to be just the thing for you. I don't believe in silver bullet cures. I just don't. Not in mental health. It's too complex. It's epigenetic. So I've got to change every facet and feature of that epigenetic influence that I can. So it's multimodal.
The lady here. Yeah.
Excellent talk. Thank you. I have a schizophrenic daughter who's 27 and a bipolar mom who's 75, and we've changed the dietary issues, huge, and we've seen great increase and improvement for both of them. It's amazing, and that's with the help of Dee as well. And so that naturopathic change. So I'm interested in a question about how successful are you in these changes that this fellow was asking about with low income people? Like, how do you make those changes when sometimes they can't afford good food? You know, their medication is supplemented. Like in Canada, my daughter's prescriptions are $2, you know, per prescription, so they just shove another prescription at her. They're not going to do the vitamin B. They're not going to do magnesium. They're not going to change things for her that way.
Well, it is a challenge, and I don't at this point work in the public health system. So I did for years. I ran treatment centers for severely abused children and worked in a community mental health center. So I know that population, and I respect the challenges there. So a couple things. One is that, and this is being done at a number of federally qualified family care centers around the U.S., where they're working with groups, low-income people with groups that provide 2 soaring deficiencies in those populations. One is a sense of connection and community, and the other is awareness of food and diet. So they do groups where they educate people about cooking and food, often in the evenings, so that it doesn't interfere with work. And what you realize is that these people are spending $10 or $15 a meal for fast food. That's horrific. And if you spend an hour and buy those ingredients in a grocery store, you can actually make a better meal for the amount of money. You have to be willing to cook it, but you have to know how to cook it. I can remember Mark Hyman, who's a functional medicine doc and works at the Cleveland Clinic Center for Functional Medicine, did a show where he went and looked at some people in southeast U.S., sort of a poverty-stricken area, and he went in their house to show them how to cook. They didn't have a cutting board or a knife. He wanted to cut vegetables, and he was hamstrung because, you know, they didn't have anything. So it's changing the culture where we actually get back to preparing food and realizing that food is our epigenetic language, and that if we don't speak the language, we're going to have problems. And so I think trying to develop like Dee is doing, you have an example of what needs to be done right here, of creating community and groups and education around food and its influence, and whether that influence is framed in the terms of inflammation or mental health. I mean, because it's going to help your knee, but it's going to help your brain too.
Dr. Maltman?
Yeah, Scott, I just wanted to, so many of us work in isolation, even if we're in a clinic. You know, with our Medicare, you know, seeing a psychiatrist, seeing a family medicine doctor is covered. But after that, I know that Amelia, for instance, suggested we weren't making basic care without having within our system the ability to have a counselor covered and various other things. And this builds on what Paul and Kathy are saying. For you as a psychiatrist, you've created a model that brings together, if you look onto your website, wholeness.com, you mentioned naturopath, but there's many people you work with. How important is it to you to be able to have this group, both for you and your mental health, but to be able to affect the change and creating this new model where you're actually all working together, and your physician intensive, I mean, your 1 week adult intensive. So how important is that?
Well,
'Cause
I would
think
say
it's
that
a new model.
if I couldn't do that, I'd probably write books and live in a cabin somewhere. Because I just was too frustrating. Having done it the other way, you know, psychiatrists by and large, you know, the people that I talk to are very frustrated with their work because it's not very rewarding. And it's not rewarding because people are not getting better at a profound level. You often create some help, but it's more episodic and it doesn't often endure. So my feeling is, and that's the reason I work with 3 naturopaths alongside me. We have 3 psychiatrists now, 3 to 4, and 3 naturopaths, because I think those carry equal weight in my view of what needs to be done for people.
And you have traditional Chinese and acupuncture and neurofeedback and all of it.
Yeah, a lot of the tools. And I think and there's probably more things I'd like to have there, but sometimes it's not practical, and it's a challenge, but yeah. And I'm trying to create this as a model where if people can see that it makes sense, then we begin to have this model in a public health setting. And, you know, it's a why not? So I think this model is preventative in the long run. It takes more effort in the short run.
Okay, I think one more question in front here.
You had mentioned helping people start getting motivated, and one of the things you said was helping with sleep issues. How do you suggest doing that? How do you help your patients with sleep issues?
Well, the first thing is you got to talk to them a lot about it and find out what are their sleep issues and what's going on. So oftentimes, you know, a single variable is trying to sort out what does their routine look like? What does their structure of their day look like? And what is the structure of the evening? Are they getting enough exercise? Diet, interestingly enough, is critical. I can remember the daughter of a physician who came to see me, this young 18-year-old, had no mental health problems whatsoever, but couldn't sleep. And she was going off to college, very successful, sort of driven student, not unlike her dad. And she couldn't sleep. And her dad had started prescribing Zolpidem for her at 14 or 15, not knowing what else to do. And he knew that wasn't a great idea, but he didn't know what else to do. And we tried a couple things. I sent her to a cognitive behavioral sleep person. I sent her, we worked on sort of sleep hygiene, the sort of things you do routinely, made sure caffeine wasn't in the way, and nothing seemed different. And I had just finished reading Grain Brain by David Perlmutter, a neurologist, of the effect of grains, particularly gluten, on the brain. And I said, well, why don't you try a gluten-free trial? You know, I was a little bit at wit's end. And she went off of gluten and started sleeping. She did well, slept, called me in the middle of her second semester saying, I'm not sleeping again. What's the problem? And I said, well, check your food. It turns out the bread that they'd been serving at the cafeteria at the college was labeled gluten-free, but it was actually regular bread. Someone had just stuffed it over there, I think not out of any malicious intent, but she figured that out and went back to sleeping. So food makes a difference. And I think looking at sugar load, looking even at the intensity of grain load makes a difference for sleep for some people. We can use supports for sleep like melatonin, magnesium. Melatonin I like in low doses that are closer to physiological, like a half or 1 milligram, not the 5 or 10 milligrams that some people use. And I think a big part of it is looking at electronics lately for people and electronic overstimulation and trying to tell people, well, by 7 or 8 o'clock at night, you need to stop surfing the web, you need to stop checking your phone, you need to stop doing this, you need to stop being on Facebook. If you want to watch a movie, sort of doing email at 10 o'clock at night, if there is one thing that will reliably interrupt my sleep is when I'm doing email at 10 o'clock at night. And so I don't do that anymore. But a sleep is complex, and I think trying to find a mix of relaxation and stress reduction, often helping people with a meditation or a relaxation approach, but trying to make sure the evenings are slowing down for them. Lighting is a big deal. Trying to make sure lighting becomes more subdued in the evening, because lighting affects melatonin secretion, affects our circadian rhythm. So a lot of it is just sort of drilling down in and removing barriers and working with them to explore and find out what helps with their sleep.
Okay, thank you very much. I think our time is up. So if you have other questions, catch the young man
I'll be up here
afterwards. So I'd like to thank Dr. Shannon very much for coming all the way from Colorado to give us this lecture on integrative mental health. Thank you very much. Just a reminder to fill in your questionnaires and evaluation of the program. And if you borrowed a pen from us, please leave it at the desk on the way out because we'll use them again. Thank you. The medical crowd, I think, has a free afternoon. And those of you who want to have a picture taken, make sure you put on your mascara and arrive early this evening for the photo taking. I think it starts at 5. Thank you very much.
Also ask for your signature so I can get credit for today's lecture.
Oh, sure.
Continuing education. But I also do Reiki and hypnotism, and I think they all fit in here as well.
Oh, yes.
But they're not recognized very much here in Middle Saskatchewan.
Well, it's coming.
It's coming, I know, but everything you said I totally love. Thank you.
You're welcome.
You too. You had mentioned low-dose melatonin. What was the reason for emphasizing
Well, our body makes,
melatonin?
maybe I should turn this off. Yes. Otherwise, everyone will hear this.